Vidal. I'm going to invite him up to the podium. He's going to present Compliance and Adherence, Identifying Life-Saving Practices.
Thank you, guys. Appreciate you coming again, and you can appreciate the passion that Dr. Porter has for this particular illness. I will still say breast is best. All right. I'm to talk about adherence and compliance. It's really not a sexy topic. It's maybe boring, but it's important. On this, my conflict of interest. So let's just talk about disparities. It exists. Why does it exist? Number of different reasons. Racial and ethnic minority groups are the patients, individuals with different ancestry, individuals with lower socioeconomy, individuals with disabilities, LGBTQ, immigrants, refugees, elderly, adolescents. Those are the people who are most susceptible to disparities in health. In Memphis, we do have a large population of blacks, African American. Here is some data showing 21% of African Americans and 18% of Hispanics, 8% of non-Hispanics white live below the federal poverty. So that's one strike. You being of color is another strike. 10% of African American, 18% of Hispanics, 5% of non-Hispanics are uninsured. That's another strike. So it's a setup for having disparities in healthcare, in health outcomes. Why does that happen? Why does it exist? There are a number of different reasons, from environmental, behavioral, social, clinical, cultural factors, psychological, biological. Today I'm going to talk about a topic of adherence, which sort of bridges clinical and behavioral factors. Are we moving? All right, what's adherence? The World Health Organization defines it as the extent to which a person's behavior taking medication, following a diet, and or executing lifestyle changes corresponds with the agreed recommendation from a healthcare provider. So I'll talk to you about, this is a study that looked at African American versus European Americans taking anti-estrogen therapy, a therapy that's been proven to save lives for patients with hormone receptor-positive breast cancer. And we show that folks of color tend to be less adherent to that medication compared to their counterparts, the Caucasian. Many different reasons for that, but that's just a fact. Here we talk about, and so this is my old slide. I updated that, but I can go through those. This is a study that we did at West here, and we published that in JAMA Network in 2021, just looking at our patient population. We selected a population of patients who had hormone receptor-positive breast cancer, who's gone through chemotherapy, gone through all of their therapy, and then had to go in and take anti-estrogen therapy and see what were their adherence. And then also, what were their symptoms at the end of chemotherapy? At West, we're fortunate that every patient who comes through gets a tablet and does a survey of their symptoms. So we are able to gather this information. So based on their GI symptoms, their gynecological symptoms, so the darker bar here is for patients of color, black patients versus white patients. We see that at the end of chemotherapy, the same type of chemotherapy going, same stage, same cancer, patients of color have worse symptoms than Caucasians. So there's a biology part to it. And when we look at the adherence to the anti-estrogen therapy after that, we see that those patients of color have less adherence, and there's a correlation between those symptoms after chemotherapy and stopping this medication. So there's a lot that goes into it, and not just that we choose not to take the medication. But I'm going to talk mainly about oral medication, but I think I'm going to touch a little bit on lung. So adherence is not only to taking medication, but adherence to screening. Here we show that patients of color, and you can see it here, who've done screening, had a negative baseline screening versus a positive baseline screening, it's more likely that the patient of color does not show up for their second screening. So we're not adherent. And that has clinical impact. This is another study looking at patients who are hormone receptor positive, stage 3 breast cancer, and the adherence to anti-estrogen therapy and the impact of that. The green bar is for the patients who are non-adherent over the years. So that last one is at 10 years. And the red is the survival if you took your medicine on time. So there is a consequence to not taking the medication. And it's not just in breast, this is CML, chronic myelogenous leukemia, for patients not taking a drug called imatinib, and the clinical consequence of that. That graph shows the ability for those patients to have what we call a major molecular response. That is a significant drop in the transcript that causes this disease. And see the separation of those graphs. If you're a 90% adherent, your chance of having really deep response is way higher than if you're not. So there is a consequence to it. So adherence facts, I'll just give you some other facts. Across these states, 50% of patients do not take their medication as prescribed. Adherence is not guaranteed by a cancer diagnosis. We often think, oh, patients have cancer, they're going to take that drug. No. Adherence to oral cancer therapy, and that declines over time. Non-adherence increases consumption of healthcare resources. Non-adherence decreases treatment efficacy. Non-adherence can lead to flawed clinical trial results. If you're participating in the results and you're not taking the medication, it's going to lead to flawed results. Poor adherence to oral cancer therapy is associated with worse disease outcome, and we showed that, including higher mortality. There are many dimensions to this adherence, and circular here, health system factors, socioeconomic conditions, related factors, treatment, therapy-related factors, patient-related factors, and we're going to go through some of those. So healthcare-related factors, what are some of those? Poorly developed health systems, inadequate reimbursement by health plans, poor medication distribution system, poor trained healthcare providers, overworked healthcare providers, lack of feedback on performance, limited consult time, poor follow-up, lack of community support, lack of adherence, social and economic factors, and we can see them here. Poor socioeconomic status and poverty, low level of education, unemployment, lack of social support, negative, unstable living conditions, long distance travel to the centers, cultural beliefs about illness, family dysfunction, race, and age. Symptoms related to your treatment, severity of symptoms, level of disability, rate of progression, severity of disease, availability of psychosocial, social, and vocational support, and that's absolutely important. And we're looking at that on the study. What is the impact of having a diagnosis on you taking your treatment and the outcomes of those, and morbid conditions? Therapy-related factors, complex medical regimens, durations of therapy matters, previous treatments, frequent changes in therapy, immediacy of the beneficial effects, side effects, availability of medical help when patients need side effect management. Patient-related factors, I'll just touch on a few: their knowledge, their attitude, their belief, their perception, and their expectations. Health systems, poor developed healthcare. Did we go back? All right, who's at risk? In a perfect world, we would have a patient who is completely motivated, no history of non-adherence, satisfied with his system, have the highest level of social support, good communication skills, no healthcare coverage issues, and have good history, no mental health issues. Perfect world, but that's not the perfect world. So a cross-sectional study of more than 10,000 pharmacy claims on oral cancer treatment drugs from between 2007 and 2009 showed that 10% of patients abandoned their anti-cancer medicine. 25% of patients had some delay initiating that oncolytic therapy. 31% of patients did not fill the entire prescription for their cancer medication. Greater than 5 prescription. If you are on greater than 5 prescription, there's a 50% higher chance of you being non-adherent. So when we have patients who are on their diabetes medications, their high blood pressure medications, and all of the other medications, and then we add more oral medications to it, there's a higher chance that they become non-adherent. Low income, there's a cost to those. That also increases your chance. And patients on Medicare. Indicators of non-adherence, presence of emotional and psychological issues, memory impairment, patients with poor provider relationship. That's us. Missed appointments, failure to obtain on-time refills, adverse effects, and high medication cost. Assessment and monitoring. Does bias influence adherence? It does. What are some of our personal biases? Does non-adherence impact attitude? Adherence assessment. How do you assess adherence in the clinical setting? Those are questions that we have to ask ourselves. What does that conversation sound like with a patient or with your partners? What kind of question can you ask a patient beyond, are you just taking your medication? Monitoring and adherence, so they are direct methods. Direct observation of the patients to see if that they are actually taking their medicines. You could sometimes monitor drug levels in the blood. You can do blood biomarkers, indirect methods, patient questionnaires, patient self-report. Those are things that we could do. EMR monitoring, rate of script refill, follow up, did the patient fill their scripts, patient's diary, pill counts, assess clinical response, and there are other systems that can also assist. Side effects can also be distressing for patients. It's a frequent cause of non-adherence. It impacts body image, decreases quality of life. We have to encourage our patients to report their side effects early so that we can help. And then we have to follow up with our patients. You know, how is this new medication to you? When I give my patient anti-estrogen therapy, I always, even when I switch it, always try to have them come back in a timely manner so I can assess whether or not they're tolerating that well. Helen Keller says, alone we can do so little, together we can do so much. It takes all of us, including the physicians, the patients, the prescribers, the pharmacy, to help get this problem. Correct prescribing, proper communication, effective education, symptom management, adherence monitoring, benefit cost advocates. And we heard about financial support. Improvement strategy. Enhance patient-provider communication. That will help. Patient education, tools for learning, monitoring side effect, adherence, and ensuring access. Communication is a two-way process. We have to listen to our patients. We have to value our patients' beliefs and preferences. We have to have open communication, maintain eye contact with our patients, communicate at the patient's level. And we heard conversation today about, the patient having the physician sitting between the patient and her husband and coming down to that level. Motivational interviewing and concordance is the goal. Patient education. Patient and family have significant educational needs. Well-informed patients have better adherence. You have to assess your patient's readiness to learn. Deliver the information verbally and in writing or electronic media, and consider the patient's age and disability when we're educating. In terms of comprehensive education, we have to educate on disease, the drug, the indication, the goals of therapy, the dosing schedule, the administration, misdosing. If a patient misses a dose, when I give your medicine, I always say, if you miss a dose, don't take 2 the next day. Just get back on it. Food and drug interactions are important. Side effects, very, very important. And we just saw the study of the side effects from chemotherapy impacting the next therapy. Clinical contact information. The patient has to be able to contact you. Dr. Ricci talked about that patient who didn't have the contact and wasn't able to get back in. Safe handling instructions. Reminder tools, calendar, daily medication checklists, multi-compartment compliance aids, pill diaries, those help. Create medication routines, keep medicine visible. I always tell my patients, put your drug next to your toothbrush. You're going to brush your teeth every day, correct? When you pick up your toothbrush, that's right there. You will remember to take it. If you're not taking it, you just don't want to take it. All right? Family, friends, get all the members to help with that. And then there are electronic reminders. Cell phone alarms, alarm clocks, smartphones, text messages, automated responses, and medication dispensers. So there are a lot that we can do in order to assist our patients in taking their drugs, because it's important. And I will end by saying this, by quoting with two quotes. One, by Hippocrates, who says, "Keep a watch on the faults of the patients, which often make them lie about taking things prescribed. For through not taking disagreeable drinks, purgative or other, they sometimes die." And finally, Everett Koop, the US General Surgeon in 1981 to 89 says, "Drugs don't work on patients who don't take them." So we have to sort of help our patient, and also the patient communication is important. And I will end here. Thank you.